Hello, my name is Keith Farnes, and the topic of this presentation is cough, acute versus chronic. It is approved by the AARC for 1 CRCE credit hour. Respiratory therapists are frequently called upon to evaluate a patient's respiratory status, which may or may not include a cough assessment. Additionally, we are often asked to explain respiratory conditions or symptoms to patients or families, so it is important to be prepared with accurate and thoughtful explanations. Here are your learning objectives for this course. When we are finished here, you will be able to define acute versus chronic cough, identify causes for each, describe symptom alleviation, and discuss patient education and counseling. Cough is one of the most common symptoms prompting patients to seek medical care. It accounts for millions of clinic visits each year in both primary care and pulmonary practices. Because cough can result from a wide range of causes, from minor viral infections to serious diseases like cancer or heart failure, it's a key diagnostic clue that requires careful evaluation. Persistent cough can lead to complications such as syncope, rib fractures, urinary incontinence, and exhaustion. Nearly every respiratory therapist will encounter cough in daily practice. Patients frequently present with cough as their chief complaint, requiring respiratory evaluation. Understanding its causes and significance improves patient outcomes and prevents unnecessary treatments. So cough is a vital airway defense mechanism designed to protect the lungs. Its purpose is to clear mucus, debris, or foreign material from the airways and prevent aspiration or infection. It is stimulated when an irritant or stretch receptors detect mechanical or chemical triggers. Then, afferent signals travel via the vagus nerve to the cough center in the medulla. This then causes efferent motor signals to trigger deep inspiration, glottic closure, compression of intrathoracic pressure, and then forceful exhalation to expel material. Cough should not automatically be suppressed. It's an adaptive reflex that maintains airway patency and ventilation integrity, although a cough can be annoying, painful, exhausting, and costly. There is a socioeconomic component to chronic or severe cough. Chronic or severe cough can be debilitating. It disrupts sleep, causes chest pain, hoarseness, vomiting, and even urinary leakage. Socially, patients may experience embarrassment or isolation, particularly in public or professional settings. Economically, cough leads to missed workdays, repeated healthcare visits, and increased medication costs. Chronic cough is also associated with anxiety and depression due to its persistence and unpredictability. Managing cough effectively improves not just physical health, but also psychological well-being and productivity, thereby improving quality of life. It also reduces the overall healthcare burden. The cough reflex is a complex protective mechanism designed to clear the airways of mucus, irritants, or foreign material. It involves 3 coordinated phases. The inspiratory phase, where a deep breath is taken to fill the lungs with air. This increases lung volume, which provides the potential energy needed to generate a strong expiratory flow. The glottis closes, and the expiratory muscles, especially the abdominal and intercostal muscles, contract, sharply increasing intrathoracic pressure. Then the glottis suddenly opens, releasing the compressed air at high velocity. This powerful airflow shears mucus or debris away from the airway walls and expels it through the mouth. So, coughing isn't just a sound, it's a highly coordinated reflex. The whole process protects the lungs from obstruction and infection. The cough reflex is controlled by a neural feedback loop that coordinates sensory input, central processing, and motor output. Specialized mechanical and chemical receptors are located throughout the larynx, trachea, bronchi, and pleura. Mechanical receptors detect stretch, pressure, or foreign bodies. Chemical receptors respond to irritants such as smoke, acid, or inflammatory mediators. Signals from these receptors travel via the vagus nerve, which is cranial nerve 10, to the cough center in the medulla oblongata of the brainstem. The cough center integrates sensory information and determines whether a cough response is necessary. This center also coordinates with nearby respiratory nuclei to time coughs relative to breathing cycles, preventing coughing during inhalation. Once activated, impulses are sent through several motor nerves. A phrenic nerve innervates the diaphragm contraction, which is the inspiratory phase. Spinal motor nerves, the intercostal and abdominal muscles, for the compression phase. And the recurrent laryngeal branch of the vagus nerve controls glottic closure and release, or the expulsive phase. All three components act in precise sequence to produce an effective cough. First you have stimulus, then you have neural detection, medullary processing, and finally a coordinated muscular response. An acute cough is defined as one that lasts less than 3 weeks. Acute cough and congestion may result from minor viral upper respiratory infections, allergic rhinitis, postnasal drip, or inhaled irritants, as well as more serious conditions such as acute bronchitis or pneumonia. Because pneumonia has many possible causes, identifying the specific etiology is key to proper diagnosis and treatment. Subacute cough is a cough lasting 3 to 8 weeks and can be a post-infection cough, or perhaps caused by pertussis, also known as whooping cough or the 100-day cough, or a resolving pneumonia or bronchitis. Chronic coughs are coughs that last longer than 8 weeks and can be caused by asthma, GERD, upper airway cough syndrome, chronic bronchitis, ACE inhibitor use, bronchiectasis, interstitial lung disease, lung cancer, etc. Besides duration, you can also categorize a cough based on location of cause: upper airway, lower airway, cardiac, GI, or even psychological. You should start with a patient interview. Ask about the onset, triggers, sputum, hemoptysis, nocturnal pattern, and medication use. As you know, meds can relieve symptoms, but that also means they can mask symptoms. It's difficult to evaluate a fever when someone has taken acetaminophen, also known as Tylenol. The patient may state their cough subsided 3 days ago, then upon further investigation, you discover they started taking cough medicine 3 days ago. Any history of chronic lung disease, immunosuppression. One of the side effects of steroids is immunocompromise. Do they have a smoking history, high blood pressure, or heart failure? Are they using ACE inhibitors? They may not know what that is. I found many patients take meds their doctor prescribed without knowing what it is or perhaps even what it's called. Mrs. Smith, which inhaler do you use? The red one. You'd want to get a heat exam, which is head, ears, eyes, nose, and throat, a pulmonary exam, cardiac, including JVP, CBC if infection is suspected, although eosinophil levels might be a good thing to know. Acute cough usually reflects an infectious or irritant cause. Chronic cough suggests an underlying airway issue, reflux, or systemic disorder. Typical red flags are fever greater than 3 days, hemoptysis, meaning coughing up blood, weight loss, dyspnea, and abnormal chest x-ray findings. Most acute coughs are self-limiting, meaning they clear up on their own. You should avoid unnecessary antibiotics. You need to evaluate chronic cough systematically and treat the most common causes first. The 3 most common causes are upper airway cough syndrome, asthma, and GERD. Review medication lists for ACE inhibitors and encourage smoking cessation. We will discuss each of these topics individually. A self-limiting cough is a temporary cough that resolves on its own without specific medical treatment once the underlying cause, usually a mild infection or irritation, has run its course. Typically, they last less than 3 weeks. Some common causes are viral upper respiratory infections, such as rhinovirus, coronavirus, or influenza. Could be bacterial, perhaps pertussis or mycoplasma pneumonia. Also, mild tracheal bronchitis. Non-infectious causes might be transient exposure to environmental irritants like dust, smoke, chemicals, or pollen, allergic rhinitis, postnasal drip, or an exacerbation of a chronic condition like COPD or asthma. So the symptoms improve spontaneously as the inflammation subsides and airway irritation clears. This requires supportive care only: hydration, rest, humidification, throat lozenges, and if needed, short-term cough suppressants. In clinical terms, a self-limiting cough is distinguished from persistent or chronic cough because it does not require antibiotic therapy and does not indicate a progressive or serious disease process. For the most part, it doesn't need professional treatment. The usual suspects for chronic cough are COPD, bronchiectasis, lung cancer, interstitial lung disease, aspiration, and aspiration of foreign bodies, which of course is mostly children. So upper airway cough syndrome is the modern term for what was previously called post-nasal drip syndrome, where mucus drainage from the nose or sinuses down the back of the throat irritates cough receptors. It is often caused by allergic rhinitis, sinusitis, non-allergic rhinitis, and environmental irritants. The patient may experience throat clearing, sensation of drainage, nasal congestion, and a persistent cough, which is often worse at night. This is treated by addressing the underlying cause: antihistamines, nasal corticosteroids, saline irrigation, or treating sinus infection if present. Again, UACS is one of the most common causes of chronic cough, along with asthma and GERD. Asthma causes a cough because of airway inflammation, hyperreactivity, and mucus production, all of which make the airways overly sensitive and prone to irritation. As you know, asthma is a chronic inflammatory disease of the bronchial tubes. This inflammation causes the lining of the airways to swell and become hypersensitive. Even mild irritants, such as cold air, exercise, smoke, or allergens, can trigger reflex coughing as the body attempts to clear the airway. During an asthma episode, smooth muscles surrounding the bronchi constrict. This narrowing increases airway resistance and airflow turbulence, which stimulates cough receptors in the trachea and bronchi. Inflammatory mediators like histamine, leukotrienes, and cytokines stimulate excess mucus production. The accumulated mucus further irritates the cough receptors and leads to a productive or dry cough, depending on severity. In some patients, cough is the only symptom without wheezing or dyspnea. This is known as cough variant asthma, and it's caused by airway hyperresponsiveness that triggers cough receptors more than bronchoconstriction does. First-line treatment will be bronchodilators and inhaled steroids. Gastroesophageal reflux disease, known as GERD, can cause coughing through both direct and indirect mechanisms, even in the absence of heartburn. It's one of the most common causes of chronic cough. Acidic stomach contents reflux up the esophagus and may reach the larynx or upper airway. Tiny amounts of this material can be microaspirated into the trachea or bronchi. The acid directly irritates the laryngeal and tracheal mucosa, stimulating cough receptors. As a result, the patient often has a chronic dry cough, often worse after meals, when lying down or at night. Even if acid doesn't reach the throat, it can stimulate vagal afferent nerves in the esophagus. This triggers a reflex arc via the vagus nerve that activates the cough center in the brainstem. Essentially, the esophagus signals the airway to cough even without aspiration. Some of the clues would be cough is chronic, meaning greater than 8 weeks, dry, often worse at night. It may occur after eating or when reclining. Associated symptoms may include heartburn, throat clearing, hoarseness, or sour taste. Cough improves with anti-reflux therapy such as proton pump inhibitors and lifestyle modification. You can suggest that they elevate the head of the bed, avoid late meals, avoid caffeine, alcohol, and acidic spicy foods. The medications used would be proton pump inhibitors, H2 blockers, or antacids. Refractory cases may require GI evaluation or pH monitoring to confirm reflex-cough relationship. ACE inhibitors, or angiotensin-converting enzyme inhibitors, are prescribed primarily to manage conditions that involve high blood pressure or strain on the heart and kidneys. Their main purpose is to block the enzyme that converts angiotensin 1 to angiotensin 2, a powerful vasoconstrictor. By doing so, they relax the blood vessels and lower blood pressure. They help reduce blood pressure and lower the risk of stroke, heart attack, and kidney disease. ACE inhibitors decrease the workload on the heart by reducing afterload and preload, helping improve cardiac output and survival. They can also help with post-myocardial infarction by preventing remodeling, which is the stretching and weakening of the heart muscle after a heart attack. They can reduce mortality and symptoms in patients with reduced ejection fraction. And they can also help with chronic kidney disease by lowering intraglomerular pressure. They slow progression of kidney damage, especially in patients with diabetic nephropathy. As mentioned, ACE inhibitors block the conversion of angiotensin 1 to angiotensin 2, but this also prevents the breakdown of bradykinin and substance P. Both are inflammatory peptides. When these peptides accumulate in the respiratory tract, they stimulate cough receptors in the airway mucosa and lungs. This causes a dry, persistent, non-productive cough. So this occurs in somewhere between 5 and 20% of patients taking ACE inhibitors. However, studies suggest the incidence is higher in women, non-smokers, and people of Asian or African ancestry. In some studies, up to 40% of Black patients report cough as a side effect compared to 15 to 20% of white patients. It can appear within hours of the first dose or months later. Typically, it is a dry, tickling, or scratchy cough without sputum. The cough normally resolves within days to weeks after discontinuing the ACE inhibitor. However, it usually returns if the drug is restarted. Of course, that would confirm the diagnosis. Listed are some common ACE inhibitors which are associated with cough. Both generic and brand names are listed. If a patient develops a cough, switching to an angiotensin 2 receptor blocker known as an ARB, such as losartan or valsartan, is typically effective since ARBs do not increase bradykinin levels. COPD causes chronic cough because of persistent inflammation, mucus hypersecretion, and structural airway changes that irritate cough receptors and trap secretions. In COPD, especially with chronic bronchitis, there is long-term inflammation of the bronchi due to exposure to irritants, most often cigarette smoke, but also dust, fumes, or biomass fuels. This inflammation leads to edema, thickening of the airway walls, and increased sensitivity of cough receptors. Even minor irritants trigger the cough reflex. Chronic irritation causes hyperplasia of goblet cells and submucosal glands, producing excessive mucus. The mucus is often thick and difficult to clear, which stimulates ongoing coughing as the body tries to expel it. This is why the classic definition of chronic bronchitis is cough and sputum production for at least 3 months in 2 consecutive years. Damage to cilia from smoking or infection impairs the mucociliary escalator, so mucus and debris accumulate. This trapped mucus further irritates the airways, creating a cycle of inflammation, mucus, and cough. Repeated injury leads to fibrosis, airway narrowing, and loss of elastic recoil. These changes increase resistance and turbulent airflow, stimulating the mechanoreceptors responsible for the cough reflex. Though bothersome, the cough is protective. It helps clear mucus and prevent airway obstruction. Management focuses on addressing both the underlying disease and modifiable causes of the cough. Bronchodilators improve airflow, reduce cough frequency, and decrease mucus retention. Inhaled corticosteroids reduce airway inflammation that contributes to chronic cough. Combination therapy such as a LABA, LAMA, and ICS will maximize bronchodilation and reduce cough more effectively than monotherapy. The goal is to reduce mucus accumulation that perpetuates cough. Some expectorants like guaifenesin may offer mild benefits for sputum clearance. Make sure they have adequate fluid intake, and humidified air can loosen secretions. CPT, oscillatory PEP devices like an acapella or a flutter, high-frequency chest wall oscillation vests can be particularly beneficial if the patient has bronchiectasis overlap. I will talk about bronchiectasis in a moment. Promptly treat acute bronchitis or COPD exacerbations with appropriate antibiotics and steroids. If they also have GERD, you should treat that. And of course, post-nasal drip UACS with antihistamines, nasal corticosteroids. Please suggest smoking cessation for these patients if appropriate. If cough persists despite optimal COPD management and comorbidity control, you could try low-dose morphine, as that may suppress refractory chronic cough in select advanced COPD cases. Specialist oversight is required. You could use gabapentin or pregabalin for cough hypersensitivity, but those are off-label use. Monitor sedation. Speech therapy and cough suppression training are emerging non-pharmacological approaches for chronic cough. Often our COPD patients also have heart failure, so be sure to avoid ACE inhibitors and limit environmental irritants like smoke, perfume, cold air, etc. Recommend vaccinations like influenza, pneumonia, and COVID-19 to prevent exacerbation-related cough. If chronic cough remains despite optimized COPD therapy, consider bronchiectasis, lung cancer, asthma COPD overlap syndrome, or possibly a chronic infection like Pseudomonas. Bronchiectasis causes chronic cough because it leads to irreversible dilation of the bronchi, resulting in mucus accumulation, chronic infection, and airway inflammation, all of which stimulate the cough reflex. The bronchial walls become permanently dilated and weakened due to repeated infection or inflammation. The damaged airways lose their ability to clear secretions effectively, causing impaired mucociliary clearance. This causes mucus pooling, which becomes a persistent irritant and medium for bacterial growth. The trapped mucus allows bacteria like Pseudomonas, Haemophilus influenza, or Staphylococcus aureus to thrive. Recurrent infections lead to ongoing inflammation, further damaging the airway walls. This creates a vicious cycle of infection, inflammation, airway damage, impaired clearance, and more infection. In response to chronic inflammation, Goblet cells and submucosal glands increase mucus production. The mucus is thick and purulent, difficult to clear, and causes daily productive cough, often with large amounts of sputum. The accumulation of secretions and infection-related inflammation stimulate cough receptors in the bronchial walls. The result is a chronic, often productive cough, the hallmark symptom of bronchiectasis. The gold standard in diagnosing bronchiectasis is high-resolution CT scan. Treatment is focused on controlling infection, clearing mucus, reducing inflammation, and preventing further lung damage. Management is typically multifaceted, involving medications, airway clearance techniques, and sometimes surgery. Clearing mucus is the cornerstone of bronchiectasis management. CPT and postural drainage. You can use positive expiratory pressure devices like an acapella, flutter, aerobica, high-frequency chest wall oscillation like vest therapies that loosen secretions, active cycle of breathing techniques, which combine breathing control, deep breathing, and huff coughing, and hypertonic saline, which hydrates mucus and improves clearance. For acute exacerbations, you could use broad-spectrum antibiotics. For chronic suppression, long-term macrolides like azithromycin can reduce exacerbations via antibacterial and anti-inflammatory effects. Inhaled antibiotics like Toby or colistin for Pseudomonas. Bronchodilators, both short-acting and long-acting agents, may help relieve airway obstruction in patients with overlapping COPD or asthma features. For anti-inflammatory agents, macrolides have both antimicrobial and anti-inflammatory actions. Inhaled corticosteroids are not used routinely but may be used if concurrent asthma or eosinophilic inflammation is present. For mucolytics, you could use nebulized saline or mannitol, can help liquefy mucus. You want to manage any underlying causes, identify and treat contributing factors like cystic fibrosis, primary ciliary dyskinesia, which I'll talk about later, immune deficiencies, allergic bronchopulmonary aspergillosis, tailored treatments like corticosteroids, antifungals, etc. If they have aspiration or obstruction, treat the underlying source. You'll want to recommend vaccination for prevention against flu and pneumonia. But you got to ask yourself, why would someone with bronchiectasis smoke? Why would someone with asthma smoke? Why does anyone smoke? These are tough questions. Regardless, smoking cessation is essential. If they smoke, see if you can get them to quit. And also, you could recommend pulmonary rehab and exercise training as they improve endurance and secretion clearance. Finally, surgery or interventional procedures for selected patients. These are localized disease unresponsive to medical therapy. You could do a lobectomy. For massive hemoptysis, maybe a bronchial artery embolization, and lung transplantation for end-stage bilateral disease. Lung cancer causes cough through multiple overlapping mechanisms, both direct effects of the tumor and indirect irritation or inflammation within the airways and pleura. Tumor invasion or compression of the bronchi or trachea can stimulate cough receptors located in the airway epithelium. These receptors, mostly rapidly adapting stretch receptors and C-fiber endings, are activated by mechanical distortion, inflammation, or tumor necrosis. The signal travels via the vagus nerve to the medullary cough center, triggering the cough reflex. Persistent dry or hacking cough that does not respond to typical therapies may become productive if there's associated infection or necrosis. A central tumor can partially obstruct the bronchus, leading to retained secretions and secondary infection. That's called post-obstructive pneumonia. Mucus stasis and inflammation further irritate cough receptors in the distal airway. A clinical clue would be change in the character of a smoker's chronic cough, or recurrent pneumonia in the same location. Tumor infiltration into the vagus nerve or its branches. This can cause neurogenic cough. This is sometimes associated with hoarseness due to vocal cord paralysis, a finding called Ortner's syndrome when caused by mediastinal involvement. Tumors invading the pleura or chest wall can stimulate pleural sensory fibers, also vagal and intercostal nerves, leading to cough that may be pleuritic or pain associated. Certain tumors release inflammatory cytokines, prostaglandins, or neuropeptides that sensitize cough receptors or increase vagal tone. This can explain persistent cough even when the primary tumor is small or peripheral. Radiation fibrosis, chemotherapy-induced pneumonitis, or post-surgical airway changes may also provoke chronic cough in lung cancer survivors. ILD, interstitial lung disease, is an umbrella term for a large group of disorders that cause inflammation and/or fibrosis, that's also known as scarring, of the lung interstitium, the tissue surrounding the alveoli. There are over 200 types of ILDs. Common causes and types would be idiopathic pulmonary fibrosis, where a cause is not identified. Hypersensitivity pneumonitis from inhaled allergens like bird droppings or mold, sarcoidosis, autoimmune diseases like rheumatoid arthritis or scleroderma, drug-induced ILD from amiodarone, methotrexate, or bleomycin, occupational exposures like asbestos or silicosis. So ILD is the general term for any interstitial lung scarring process, no matter the cause. ILD is characterized by progressive scarring and the usual interstitial pneumonia pattern seen on high-resolution CT scan or biopsy. It typically affects older adults between 50 and 70 years, leads to gradual worsening shortness of breath and dry cough. So to break this down, the inflammation irritates sensory nerve endings in the airways and lung parenchyma, especially in the vagal C fibers and rapidly adapting receptors. These receptors trigger the cough reflex when activated. Fibrosis makes the lungs stiffer and less able to expand. The increased mechanical stress and stretch on airway walls further stimulate cough receptors. This is why many ILD patients have a dry, hacking, non-productive cough. It's reflexive, not due to mucus buildup. Even though ILD primarily affects the interstitium, it can also cause parabronchial inflammation around the small airways, bronchiolar distortion, and traction bronchiectasis, both of which mechanically irritate cough receptors. These small airway changes add to persistent cough. And it also causes neural hypersensitivity, where chronic inflammation in ILD can make cough reflex pathways hypersensitive, similar to what's seen in chronic cough syndromes. Even minor stimuli like talking, laughing, or cold air can provoke coughing. This is called cough reflex hypersensitivity. A cardiac cough is a reflex cough caused not by lung disease but by the heart's dysfunction, most commonly left-sided heart failure or severe valvular disease. Although when one ventricle fails, the other usually isn't far behind. When the left ventricle fails or mitral valve disease causes elevated left atrial pressure, blood backs up into the pulmonary veins and capillaries. This blood backing up leads to increased pulmonary venous and capillary hydrostatic pressure, resulting in pulmonary congestion and interstitial edema. Fluid accumulation in the parabronchial and interstitial tissues irritates juxtacapillary J receptors and bronchial mucosa cough receptors. These mechanical receptors and C fibers respond to interstitial fluid stretch, increased pulmonary pressure, and chemical mediators. Their activation triggers the vagal cough reflex, which I described earlier. Thus, even without infection or airway obstruction, the heart failure-related pulmonary congestion alone can cause a persistent dry cough, especially when lying flat. ACE inhibitors, which are used to treat heart failure and hypertension, can also activate airway sensory nerves, compounding the cough, which I described earlier. Cardiomegaly or enlarged left atrium may mechanically compress the left main bronchus, producing a cough or hoarseness. Ciliary dyskinesia, also called primary ciliary dyskinesia, PCD, is a rare inherited disorder in which the tiny hair-like structures called cilia, found on the surface of the respiratory epithelial cells, do not function normally. Cilia line not only the respiratory tract, but also the sinuses, middle ear, and reproductive organs. Their coordinated wave-like motion helps to move mucus, bacteria, and debris out of the airways, keep the sinuses and ears clear, and support fertility by moving sperm and eggs. So in PCD, the cilia are structurally or functionally abnormal, leading to impaired mucociliary clearance. This allows mucus and pathogens to accumulate, causing chronic and recurrent infections of the sinuses, middle ear, and lungs. Over time, this can result in progressive lung damage similar to cystic fibrosis. It is caused by genetic mutations that affect the proteins responsible for ciliary structure and motion. Key clinical features would be a chronic wet cough starting in early childhood with recurrent pneumonia or bronchitis, chronic sinus infections, middle ear infections, often leading to hearing loss, and it can also cause infertility. There is no cure, but management aims to reduce infection and preserve lung function, using airway clearance therapy like chest physiotherapy or oscillating devices, antibiotics for infections, inhaled bronchodilators or mucolytics, routine sinus and ear management, and lung transplant in severe end-stage cases. A psychogenic cough is a chronic dry cough that occurs in the absence of organic pathology such as asthma, infection, GERD, or postnasal drip. It is considered a functional disorder, meaning the cough reflex is real, but driven by psychological stress, anxiety, or attention-seeking behavior, not physical irritation. Typical characteristics are a dry, repetitive, harsh, or honking sound. It disappears during sleep or when distracted, and it can worsen with stress or anxiety. It often lasts weeks to months. It can be triggered with emotional distress, school or work pressure, anxiety, or habit formation after a respiratory illness. It does not improve with typical cough treatments or antibiotic, but improves with behavioral therapy. It is a diagnosis of exclusion, meaning all organic causes must be ruled out first. They have a normal chest x-ray and spirometry, no evidence of asthma, infection, GERD, or postnasal drip. Sometimes it is associated with other somatic symptoms like throat clearing, vocal tics. Once other causes are excluded, psychogenic cough can be diagnosed. The exact cause isn't fully understood, but several factors contribute. Heightened cough reflex sensitivity triggered by emotional stress, conditioned response where the body learns to cough even after the initial illness is gone, and psychological reinforcement such as attention or habit loop perpetuates the cough. It is common in children and adolescents, most often school-aged, but sometimes adults under high psychological stress. It may coexist with anxiety, depression, or obsessive-compulsive traits. Because the origin is psychological, treatment focuses on behavioral and psychological interventions, not medications. Reassurance and education, explaining the mechanism reduces anxiety, behavioral therapy or habit reversing training, speech therapy to retrain breathing and vocalization, and cognitive behavioral therapy for underlying anxiety or stress, and distraction techniques such as breathing exercises, relaxation, and humming. Aspiration refers to the entry of foreign material, most commonly food, liquids, saliva, or gastric contents, into the airway below the level of the vocal cords. The body's primary defense mechanism against this invasion is the cough reflex. When aspirated material reaches the larynx, trachea, or bronchi, it irritates the mechanical receptors and chemoreceptors located in the airway lining. These receptors send signals via the vagus nerve to the cough center. The cough reflex produces a sudden, forceful expiration meant to eject the foreign material and prevent it from reaching distal airways or alveoli. Small or repeated aspirations, especially in those with weak reflexes such as stroke or elderly patients, can lead to chronic inflammation and infection, known as aspiration bronchitis or aspiration pneumonia. Gastric acid aspiration can cause chemical pneumonitis, damaging the alveoli and leading to persistent cough, hypoxemia, and respiratory distress. The clinical features include immediate cough after swallowing or eating, that's a classic sign, wheezing, gurgling voice, or stridor if material is in the upper airway. Recurrent or persistent cough in at-risk populations, such as neurologic disease, GERD, or sedation. Recurrent pneumonia, especially in the right lower lobe due to bronchial anatomy. To get to the diagnosis, observation during swallowing using clinical or video fluoroscopic studies, chest x-rays or CT showing infiltrates in dependent lung zones, and bronchoscopy if foreign material or food particles are suspected. You want to encourage coughing or suction if available to clear the airway. You could suggest elevating the head of the bed greater than 30 degrees. Use swallowing therapy or modified diets. Treat reflux if present. Avoid sedatives when possible. If infection develops, you're going to treat as aspiration pneumonia with appropriate antibiotics. Hemoptysis is the coughing up of blood or blood-streaked sputum from the lower respiratory tract, meaning below the vocal cords. It is important to distinguish this from vomiting blood from the GI tract or bleeding from the nose or throat that is merely coughed up. Cough and hemoptysis are closely linked because the act of coughing often triggers or reveals the bleeding. In most cases, patients report that they coughed up blood, not that they were bleeding and then coughed. Cough as a trigger would be when increased airway pressure during forceful coughing ruptures fragile blood vessels in inflamed or damaged airways. Coughing as a symptom would be coughing which helps expel the blood that accumulates in the airways due to underlying pathology. So hemoptysis nearly always presents with coughing, not as a silent bleed. Common causes are infectious bronchitis, pneumonia, tuberculosis, inflammation, and capillary rupture. Bronchiectasis, lung abscess, dilated or eroded vessels and damaged airways, lung cancer, tumor invasion of bronchial vessels, pulmonary embolism, mitral stenosis, pulmonary infarction, or venous congestion. Also can be caused by trauma, anticoagulant use, autoimmune disorders, and vessel injury. You want to check if it's just blood-streaked sputum, which would be minor, versus large volume, which would be massive hemoptysis, bright red and frothy from air mixing. That would be atypical of a pulmonary source. They might have a productive cough, fever, weight loss, chest pain, or shortness of breath, depending on the cause. As I mentioned, be sure to differentiate this from GI or nasopharyngeal sources. Use a chest x-ray or CT scan to localize the lesion, bronchoscopy for visualization and possible control of bleeding, and sputum culture or cytology to identify infection or malignancy. You'll want to stabilize the airway and possibly give oxygen. Treat the underlying cause with antibiotics, bronchoscopy for tumor or embolization of bleeding vessels, etc. Try to avoid excessive coughing if possible, using humidification Antitussives or positioning may help limit irritation. Remember that hemoptysis is not a disease but a symptom. The cough brings the blood to attention, but the source of the bleeding is within the bronchial or pulmonary circulation. Identifying and treating that source is key to management. Smoking cessation refers to the process of quitting tobacco use, particularly cigarettes. It's one of the most effective interventions to improve respiratory health, reduce chronic cough, and prevent or slow diseases such as COPD, lung cancer, and cardiovascular disease. It involves behavioral strategies to identify triggers such as stress, alcohol, driving, social settings, pharmacological support, which are used to reduce withdrawal symptoms and cravings, such as nicotine gum, patches, lozenges, inhalers, nasal sprays. Non-nicotine medications like bupropion, which reduces cravings and withdrawal. Motivational techniques, which focus on personalized benefits, better breathing, saving money, protecting family, etc. Importantly, after quitting, they should expect a temporary increase in cough and mucus productions as their lungs clear. Reinforce that this typically resolves within 2 to 4 weeks. Encourage continued abstinence even if symptoms briefly worsen. Smoking cessation is the single most effective therapy for chronic cough and airway disease prevention. Even a brief counseling session by a respiratory professional can double a patient's chance of quitting successfully. You should start patient education with understanding. Begin by assessing what the patient already knows or believes, such as, when did your cough start? What do you think is causing it? Identify misconceptions. Many patients expect antibiotics for every cough or think a cough must mean infection. Review duration, acute versus chronic, and characteristics, dry versus productive. And your goal is to build rapport and tailor education to the patient's understanding. Explain the purpose of a cough. Identify and manage triggers. Promote supportive care for self-limiting acute coughs. Emphasize comfort measures such as stay hydrated, avoid unnecessary antibiotics, encourage rest and good nutrition, and recommend over-the-counter medications when appropriate. Empower the patients to know when to seek further care, a cough lasting greater than 3 weeks, if they start coughing up blood, have shortness of breath, fever, weight loss, or night sweats, or new symptomatic symptoms. You can say something like, if your cough changes character or you start coughing up blood, call your provider right away. Reinforce adherence and follow-up and provide educational materials. Be sure to use the teach-back method, meaning ask the patient to explain it back to you to make sure that they understood what you said. Remember, good counseling turns anxiety into understanding. Patients who understand why they cough are more likely to follow treatment, avoid unnecessary antibiotics, and recognize when to seek help. Let's take a moment to summarize what we covered. We began by characterizing cough by duration, acute lasting 3 weeks or less, often self-limiting and requiring only supportive care. Chronic, persisting more than 8 weeks, which warrants further evaluation to identify underlying causes. We also classified cough by location or origin, upper airway, lower airway, cardiac, gastrointestinal, or psychological. From there, we explored a variety of common and clinically important causes. Upper airway cough syndrome, formerly known as postnasal drip. Asthma, including cough variant asthma. GERD as both a direct and indirect cause. ACE inhibitor-induced cough. COPD, bronchiectasis, lung cancer, interstitial lung disease, cardiac cough, ciliary dyskinesia, psychogenic cough, aspiration, and hemoptysis, recognizing it as the coughing up of blood from the lower respiratory tract, an important sign that always requires further investigation. And finally, we wrapped up with smoking cessation. With that, I will leave you with this thought. Want to be the least popular person in a crowd? Start coughing. And that brings us to everyone's favorite slide, the end.